So first of all, I'd like to thank Dr. Ashish for having me here. So wishing you best of luck for this grand mega event. So joint replacement is a highly predictable surgery, but it is surgeon dependent. I have this. And whenever this peripositive joint infection occurs, it's a surgeon's nightmare. And whenever this devastating complication occurs, the patient and the surgeon passes through these stages of grief. Initially, both the patient and the doctors are in the phase of denial. Then the patient goes in anger, the depression for the doctors. Then comes the phase of bargaining, means the litigations. And finally, we reach to the acceptance. So this is a study from the Mayo. The rate of infection in the primaries is around 1.7% and revisions is around 3.2%. Coming on to Indian scenario, the worst in every aspect. Number of arthroplasty, we don't know. Number of complications, hardly documented. Training, questionable. Accountability, nobody is accountable. So why it is different in India? Because we are just too many. More than 150 million people. More than 1 million diseases. Neglected diseases very commonly. And poverty is the factor. So solution. I think the greatest mind that India has ever produced, the product of nepotism. Some Gandhi has suggested a solution. The caste census. Welcome to India, sir. So I will start with 3 cases. Case number 1, done by my best friend with a robotic technology, 78 years old lady, 10 debridements, presented with this, placing for amputation. I kept on convincing her that this can be saved, but she kept on urging that I need amputation. I had to amputate it. Another case, another victim of robotic joint replacement, done in Delhi. This case, the surgeon did this arthrodesis, came to me with neglected ankle fracture. So just operated her yesterday with ankle arthrodesis. Another case, operated in Delhi, bilateral knee replacement. Patient came to me with this. 3 months post-op. This was the infection. So got operated Delhi, came back to Patna, presented with this kind of pus discharging. So decided to do it in 2 stages. Stage 1, removed it. It was a gold knee. Did in 2 stages. This is yes from Noyles with sleeves over the femoral and tibial side. This is a 2-year follow-up. And this is the patient's video, walking painlessly, fully mobile, retaining the function. So joint replacement is today reaching small town and setup is in wrong way. Wrong way means these company guys have become the chief surgeon and our surgeons have become assistant. These company guys dictate the implant and the technology. They decide the implant design and which technology to be used or not. So the number of complications are increasing. Total joint replacement is earning a bad name and we are losing faith of the patient. Regarding these newer technologies, as we all know, these robotics increase operating time around 15 to 20 minutes. So this is a well-known fact to everyone. As your operating time increases, your rate of complications like infection will increase. Not only to this increase operating time, there are some associated factors like you need to have presence of this robotic arm, sensors, imaging modalities. You need to have some other person in the operating rooms as well. So these all factors lead to increased joint infection rates. So whenever I say these joint infection to my robotic friends, this is their reaction. This is Newman from USA who has published this Mad magazine. So this is the reaction. What? Me worry about joint infection? But actually you should. Look at this literature from JBJS. The in number of literatures I can go on publishing. And the conclusion is one. Joint infection rates is at least twice the manual joint replacement rates. So the fact is, joint infection rate is on a rise. Why? Because we are looking for it. And infections are common, and above all, we are operating on the patients whom we would not have operated in the past. So as joint infection is on the rise, the interest in joint infection is on a rise. So look at the number of publications that had risen in the last few years. So today, the number one concern among the orthopedic community is the joint infection, because it causes high morbidity. It can kill. PGI is worse than few of the cancers. So coming on to the management, I will discuss in three parts: the prevention, how to diagnose it, and how to manage it. So people keep on asking me, what is the most important step to prevent infection? I can say there's not a single step, it is a number of steps. So in human body, there are around 40 trillion cells, and each cell contains 3 microbes. So there are around 120 trillion microbes in our body. We live in a harmony with these microbes. Whenever there is an imbalance in this equilibrium, infection arises with the advent of dysbiosis. So what are the 10 approaches I use? Number one is host optimization. You need to know when to operate or not. Diabetes, uncontrolled diabetes. So what's the cutoff? So my cutoff is HbA1c less than 8. But there are certain recent markers like serum fructosamine, which has been used nowadays to know whether your glycemic index is controlled or not. Reduce the bio burden. Ask the patient to take a shower one day before or the same day of the surgery with a soap. Use betadine scrub, chlorhexidines, and shaving. Perioperative antibiotics. Use antibiotics within 1 hour of your incisions, and I personally use 1-shot antibiotics after my tourniquet is off. Respect the soft tissues. Don't touch this soft tissue with your gloves. Remember, your gloves are contaminated. They are not sterile. Expedite the surgery. Try to finish surgery as early as possible. You're not in a picnic. You're not here to enjoy the music in the operating room. So try to finish it early. So minimize foot traffic. Every person in the operating rooms must be serving some purpose. Every person entering the operating room will bring some new bacteria. So minimize blood loss with hypotensive anesthesia and use of tranexamic acids. Implants. Your implants are a source of infections. Don't allow your implants to be touched by the soft tissues. So remove bioburden prior to the closure by pulse lavage. Wound management, you have to prevent the hematoma. Drain or no drain is a matter of questions which can be debated. I personally use the drains, and I don't use any anticoagulants, potent anticoagulants. Mostly I use aspirins and mechanical prophylaxis. So this is a common scenario in our operating theaters. Look at this endoclinic. I was here. 5 surgeries are going on, still 0% infection rate. They have this Drager opera system. So I don't advocate using laminar air flow, but that your operating room must have a good ventilation with a positive pressure. So your space suits are even not required. You must have good ventilation with a positive pressure. So I operate more than 1,000 joints in a year. Overall infection rate is less than 1%. So I haven't thought to give antibiotics till suture removal, but I normally give 3 doses of antibiotics, mostly for the infections harboring in the patients. So coming to diagnosis, early diagnosis is the key, and that depends on high index of suspicions, and that is mostly clinical and investigative. So clinical, the pain, the wound, sinus. Apart from this, these are the various markers. If the culture is positive, you know it's an infection. There are in number of laboratory investigations are available, but no one is complete. I think the most important investigation is synovial fluid total count and differential count. That is the most diagnostic. So whenever you are in doubt, go for joint aspiration. Under sterile conditions, do the cultures and do the total count and the differential count. That will give you the idea of the joint infections. So 2 things are very common. One test is not going to yield you the results. Now the era of biomarkers are here. They are going to stay here. But the future will be detecting these biomarkers from the serum. So the serum procal, interleukin 6, synovial fluid alpha defensine, and leukocyte by Javed Parvizi, they have been game changers. So one important thing I would like to highlight, the microbes present in the joints don't travel in the blood. So it's very hard to get any kind of investigations from the serum. So the future will be detecting these free DNAs from the blood. So I am just thrilled about advent of this microfluidics and next generation sequence technique. So X-rays mostly are normal. If this kind of X-ray is there, you know this infection is there. Nuclear medicine has a role. So coming on to management, the goal is to eradicate the infection and restore the function. So the options are debridement with retention of the implant, but the time limit is 3 weeks. After 3 weeks, there is very little chance you can retain your implants. So you can do the single stage revision, 2-stage revision, or orthodesis or amputation in case of knee arthroplasty. So for the retention of implant, it has to be early and it will be surgical. And it's both mechanical and chemical. Early pulse lavage is most important. We exchange all the mobile parts. So never hesitate to open whenever you are in doubt. So my approach, this is a case, bilateral knee, done at PGI Chandigarh. Patient came 3 weeks post-op with discharging sinus from the right side. So this is what I do with the debridement and retention of the prosthesis. I do it in 2 stages. So what I do, I thorough debridement with the use of a toothbrush. I remove all the biofilm from the implant surfaces, remove that poly is scrubbed, and this same poly is reinserted with antibiotic cement beads with high dose of antibiotics into it. After 5 days, reopen it, remove all the antibiotic cement beads, and then exchange the new modular part. So I debride it in 2 stages. This is I debride with toothbrush, use the antibiotic cement beads, and this is the final follow-up. And this is the 5-year follow-up, 0 infection. So I got as inspiration by Mayo Clinic from the Henry Clark, they have published it. I occasionally use this stimulant as well. So single stage removal of implant, debridement, and exchange in the same setting. See my teacher, Thurston Garke from Endo Clinic. So this saves time and money, but requires anti and vigilance of the organism. So gold standard is 2-stage revisions. In the stage 1, you remove the implant, remove the debris, debride it, and antibiotic cement spacers are produced. Then you put the reimplantation in the 2nd stages. So one new thing has come up. These PGIs are mostly polymicrobial. So by this culture, you mostly detect the dominant ones and misses the others. So I think the most important thing nowadays will be the next generation sequencing. So over this NGS, if you see multiple sequencing are there, you have to go with the 2-stage, not the single stage. So one of the most challenging aspect is, and people keep on asking, when to do the second reimplantations. So this is the most challenging aspect. So I typically rely on D-dimers. My cutoff limit is 850. So if 850 is there, my infection is controlled. Mind it, I didn't use the eradication word. I use controlled. Because infection can never be eradicated. It can either be controlled or not controlled. So if my infection is controlled with a D-dimer value less than 850, I will go on the 2nd stage of reimplantation. So these are the antibiotic cement spacers. Cases, bilateral knee, periprosthetic fractures, done again at Delhi by one of the best surgeons. Infected, these are mobile bearing inserts. Insert got dislocated. You can see both the metallic implants touching with each other. Came to Patna, 6 months over bed. Revised with 2 stages. This is the Indo model hinge. This is the other knee as well. This is a 6-year follow-up. Another case, done outside. Revised it with Indo model. This is a 1-year follow-up. Another patient from Nepal got this accident with polytrauma. X-fix was applied, some other fractures were there, treated, patellar fractures got infected. So this was the knee. So this was the cement spacer placed. So I did this Indo model hinge. So this was the patient, and this is the moment after around 20 surgeries. And from here, this is the movement. So my take-home message will be, the surgeon must have a suspicious mind and a trained eye. So never underestimate the infections. Pre-op planning should be meticulous. Inter-op hygiene is a must, and rigorous post-op protocol is very important. Thanks a lot for your patient hearing. Thank you.
Thank you, Nishikant sir, for sharing valuable thoughts on this complicated topic. Now I call upon